How private equity actually makes money in healthcare. Okay, so here's the thing. The model isn't complicated. It's buy load with debt, cut costs, raise prices, flip fast. That's the spine. But the muscle is the incentives wrapped around it. Fees, real estate, and accounting moves that make numbers look better while care gets thinner. Why healthcare? 3 reasons. First, inelastic demand. When you're hurt, you don't shop, so price hikes stick. Second, opaque pricing. You can't compare a CT scan the way you compare airline tickets. Third, insurers buffer pain. You don't feel the full cost up front, which lets providers and carriers fight over bigger numbers while you get surprise leftovers. Now the leverage lever. Private equity rarely buys with cash. They borrow against the company they're buying, so the target carries the loan. Interest payments become a monthly pressure cooker. On top of that, the fund charges management fees to the company. Then comes special dividends. Cash paid out to owners by taking on even more debt. Add sale leasebacks. Sell the clinic or hospital building to a landlord they control or a REIT, then lock the operating company into rising rent. The real estate gets a steady yield. The clinic gets a new fixed cost it can't avoid. This is where the efficiency story breaks. To hit debt service and rent escalators, they need EBITDA to climb. So they game the metrics. You'll hear EBITDA add-backs, accounting adjustments that treat one-time costs as if they don't count, or add hypothetical savings that haven't materialized. On the ground, there's throughput. Shorten appointment times, raise productivity targets, and push high-margin codes. Staff-to-patient ratios creep down. Skill mix tilts toward less expensive labor. Quality measures get reframed toward what's easy to hit. Regulatory arbitrage keeps it humming. A fragmented landscape of clinics and specialty groups sits under hospital-level scrutiny. Small practice rollups fly below antitrust reporting thresholds. Ownership structures hide who's in charge. The result, consolidation without obvious big merger headlines. Let me show you how each piece pays. Management fees, guaranteed cash to the fund regardless of performance. Dividend recapitalizations, early payday long before real value's created. Sale leasebacks, extract equity from real estate today, convert it to rent forever. If the business slows, that rent doesn't. So prices rise, add-ons multiply, and staffing gets trimmed to protect covenants. What gets optimized is coding and collections. The most profitable unit isn't a nurse or a vet, it's a claim. That's why you see emphasis on high-acuity codes in ERs, bundled diagnostics at vets, crowns and aligners in dentistry, and therapy thresholds in nursing homes. The playbook tunes every step to maximize reimbursable events per visit. Now about efficiency. In theory, scale lowers supply costs. In practice, those savings don't routinely flow to patients. They often get captured to service debt or fund dividends. Meanwhile, the harder-to-measure parts of care, time, judgment, continuity, are exactly what gets squeezed. There's also the exit clock. Funds aim to sell in 3 to 7 years. That timeline shapes decisions. Long-term investments that pay off in year 8 lose to short-term boosts that help this year's EBITDA. If the flip is to another fund, the cycle resets with fresh fees and debt. If it's an IPO or a carve-out, assets with reliable cash flows, like real estate or ambulatory surgery, get ring-fenced, while the riskier core gets left with obligations. You might be thinking, isn't some of this normal corporate finance? Sure, in moderation. But healthcare has special properties. Captive demand, life and death stakes, and third-party payers. When you overlay high leverage, it doesn't just compress margins, it pushes clinical behavior. Scheduling algorithms prioritize revenue density over clinical complexity. Staffing budgets treat human variability like a controllable input. And when the numbers miss, the remedy isn't more time with patience. It's another round of cuts or a new revenue line, credit cards, wellness plans, optional diagnostics that somehow become mandatory. Here's a microstory that captures the incentives. Last week, a viewer sent me a vet invoice, routine limp, recommended x-ray, blood work, and a comprehensive wellness panel, bundled at a discount. The vet admitted the panel wouldn't change treatment that day. So why push it? Because bundles smooth revenue, meet monthly targets, and help service rent they didn't use to pay after a sale leaseback. Everything changes when you see the capital stack. Senior lenders want predictable cash. Mezzanine and PIK interest piles on. Covenants force adjustments when performance slips. The operators don't wake up hoping to cut corners. The debt calendar makes it inevitable. Once you understand the machine, the case studies hit harder. ER staffing groups didn't stumble into out-of-network strategies, they engineered them. Vet roll-ups aren't just branding plays, they're debt servicing engines. Nursing homes don't understaff by accident, it's how the spreadsheet balances. And dental/vision DSOs don't love upsells because they're greedy by nature. The KPI culture flows from financing demands. Keep that map in your head. Next, we're going to the ER, where surprise bills weren't a glitch, they were a business model by design. The ER takeover, surprise bills by design. Here's what actually happens when you walk into an emergency room. The hospital might be in network. The room, the bed, even the aspirin might be in network. But the doctors treating you? They could be staffed by a separate company that's out of network on purpose. That separation, hospital versus physician staffing group, was the wedge private equity used to turn your crisis into a high-margin billing event. This is not rare. Two firms, Blackstone's Team Health and KKR's Envision, at one point touched roughly a quarter of all ERs nationwide. Most people think surprise bills were random mistakes. They weren't. Consolidation created a few giant staffing firms that negotiated with insurers from a position of strength. Pay our rates or we go out of network and balance bill your members. Blackstone's Team Health and KKR's Envision became the two biggest players. They rolled up emergency physician groups nationwide, then used out-of-network leverage to demand higher payments. When insurers pushed back, the firms escalated, arbitration, litigation, and before the law changed, sending bills to patients that landed like grenades. They even funded a dark money campaign, Doctor-Patient Unity, spending tens of millions of dollars to scare Congress away from stronger surprise billing protections. Now, this is important because the choice to go out of network wasn't about clinical freedom. It was a pricing tactic. ER visits are inelastic. You can't schedule your car crash for a cheaper day. So when the company behind the doctor is ON, they can bill a much higher charge master rate, then balance bill you the gap. The threat alone often pulled insurers into paying more to keep their members from exploding on social media. Then came the No Surprises Act. It stopped most balance bills for emergency care and created an arbitration system to settle disputes between providers and insurers. Problem solved? Not quite. The law left loopholes and created a new battleground. Independent dispute resolution, where both sides submit numbers and an arbitrator picks. Guess who floods that system? Private equity-backed groups. Filing volumes spiked, costs piled up, and many cases were driven by a handful of firms. Early analyses show high provider win rates in some markets, with mass filings used as leverage. The tactic shifted from billing patients to gaming arbitration. Here's the setup payoff. When surprise billing got capped, the playbook didn't disappear. It morphed. Staffing companies leaned harder on coding intensity, pushing higher acuity codes that pay more. They tightened visit times but documented more complexity. They understaffed to cut costs, then squeezed remaining clinicians with throughput targets. The spreadsheet wins when a visit looks sicker on paper and costs less to deliver. Microstory. A viewer took their kid to an in-network ER for stitches. The hospital bill was modest. Weeks later, a 5-figure statement from a physician group nobody recognized arrived. The group wasn't the hospital. It was an LLC tied to a national staffing firm. Pre-NSA, that balance bill would have been their problem. Post-NSA, the insurer and staffing firm fought in arbitration. The family still got collection notices, while the adults argued. The lesson: the entity on the bill wasn't the hospital, it was the business model. But here's where it gets interesting. Negotiations between insurers and staffing firms resemble hostage-taking because the ER can't close. If a big staffing firm walks, the hospital scrambles to fill shifts. If the insurer refuses to pay, members suffer blowback. That structural leverage lets private equity-backed groups demand higher rates than independent physician groups ever could. And when rates stick, the extra dollars don't fund better staffing. They fund debt service and dividends upstream. You might be thinking, didn't the No Surprises Act fix patient pain? It protected many patients from direct balance bills, yes. But it didn't fix the incentives. Providers can still threaten out-of-network status to force higher in-network rates. They can file mass arbitration claims to raise the cost of resistance. And they can keep narrowing schedules, rotating temporary clinicians, and cutting support staff to meet financial targets. The harm shows up in a different column. wait times, misdiagnoses, and as several studies suggest, worse outcomes tied to staffing reductions after private equity acquisitions. Everything changes when you look at the operational playbook. Recruit aggressively, churn physicians who push back, replace with cheaper labor where state rules allow. Use centralized billing to optimize codes. Enforce downtime caps and charting templates that nudge visits higher on the severity scale. Drop in a professional services fee on top of facility charges. If regulators tighten one screw, turn another. There's one more angle: joint ventures with hospital systems. Some staffing firms embed inside large chains, spreading their model across dozens of ERs with standardized contracts. That scale helps in arbitration, lobbying, and PR. Remember the dark money ads warning about government rate setting? Those weren't grassroots. They were funded by the very groups profiting from surprise billing, through doctor-patient unities ad blitz. So what's your move? First, check your explanation of benefits for a separate physician services line from a company you don't recognize. Look for emergency physician services, professional services, or an unfamiliar LLC. That's your ownership clue. Second, if you get an ER bill that feels off, call your insurer and ask specifically whether the professional component is protected under the No Surprises Act. Document everything. If collections start, file a complaint with your state insurance department and cite federal protections. If they could design surprise bills into ERs, where you legally can't shop, then vet care, where there's almost no equivalent protection, is a wide-open field. Let's go there next. Your pet as a profit center, veterinary Rollups. If they engineered surprise bills in ERs, vet care, with No Surprises Act, no insurer backstop for many visits, and lots of emotion, is target-rich. This is a market already dominated by a few giants. Mars Incorporated owns thousands of clinics. JAB Holdings NVA controls over 1,000, with VetCOR, Thrive, and regional Rollups filling in the map. Here's what actually happens when a consolidator buys your local clinic. The name on the door stays. The staff mostly stays. But the owner becomes a chain backed by a fund, and overnight the incentives shift from relationship medicine to monthly targets. Step 1 is quotas. Regional managers visit with dashboards. Diagnostics per visit, pharmacy capture rate, case acceptance percentage on dental cleanings, average transaction value. Appointments shrink from 30 minutes to 20, then 15. Vets are told to practice to standard, which means standardized protocols built to maximize reimbursable steps. More blood work panels, more imaging, more branded meds instead of generics. Price escalators kick in quietly. You'll see diagnostics bundles for routine issues, CBC, chemistry panel, thyroid urinalysis, pitched as comprehensive, even when the case is straightforward. Branded flea/tick and heartworm preventives get pushed with auto-ship enrollments. Wellness plans promise savings but lock you into monthly fees and create visit cadence the chain can forecast. Each of those lines props up EBITDA, which, remember, feeds debt service, rent from sale leasebacks, and management fees upstream. Debt isn't abstract here. Many roll-ups buy clinics with borrowed money, then sell the building to a real estate entity and lease it back with annual rent escalators. Suddenly, the clinic owes a fixed, rising rent to a landlord aligned with the investors. How do you guarantee that cash? You raise prices and increase the number of billable items per visit. That's why an X-ray that used to be "let's see if it's needed" becomes recommended, or even required before we proceed. Shortages get exploited too. There's a genuine vet workforce crunch, burnout, retirements, and fewer specialists in some regions. Consolidators leverage that scarcity. They raise prices citing market rates, bring in locum vets at higher hourly costs but shorter shifts, and pass costs along. Wait times stretch, urgent slots vanish, and when you finally get seen, you're steered toward the high-margin path because the day's schedule is overstuffed. Here's the moment care gets compromised. The script overrules judgment. A limping dog with classic soft tissue strain might benefit from rest and NSAIDs with a watchful follow-up. The corporate protocol inserts immediate imaging, full labs, and a recheck bundled into a plan. The vet who says "let's wait 48 hours" gets flagged for underutilization. Repeat that across thousands of visits, and you see how targets reshape medicine. Microstory. A subscriber wrote me after a routine dental cleaning quote jumped from $350 to $1,100 after a buyout. The new estimate bundled pre-op blood work, 2 sets of x-rays for fluids, pain injections, branded antibiotics, and a post-op care package, plus a membership discount if they joined a wellness plan. When they asked which items were optional for a healthy middle-aged cat, the coordinator said, "Our standard of care requires them." That phrase, standard of care, has become a pricing shield. Another lever is pharmacy capture. Independent vets used to hand you a script. You'd fill it online. Chains push in-house pharmacies with manufacturer rebates and guarantees, or they'll quote extended fulfillment times for outside scripts. Some charge prescription handling fees if you insist on a third-party supplier. Margins on meds help cover rent escalators far more predictably than seasonal services. You'll also notice more care coordinators and fewer long-tenured techs. Coordinators sell plans and manage financing. Tech turnover saves on wages and keeps the mix cheaper. Meanwhile, clinics add deferred interest credit cards at checkout. Those 6-, 12-, or 18-month promos look friendly, but can backload interest if you miss a window. It's dentistry's playbook, ported to pets. Now, to be fair, some chains bring new equipment, extended hours, and access to specialists. But the savings from scale, bulk purchasing on meds, lab contracts, rarely flow to you. They're captured to service the capital stack. If the fund took a dividend recap, the pressure to extract cash intensifies. And if a chain splits real estate from operations, the rent ratchet keeps clicking regardless of local demand or seasonal downturns. How do you spot a Rollup? Subtle name tweak, new consent forms with affiliated with fine print, wellness plan pitches at check-in, and branded merch in the lobby. Ask who owns the practice and whether it's part of a larger group. Watch for scripted upsells. We recommend the gold package today. Our protocol is, it's required to proceed. Those are tells. So what's your move? Before agreeing to bundles, ask, which items change today's treatment? Request a written estimate broken out by line item, and circle anything not strictly necessary. Ask for generic meds, and if they push back, request a written prescription and compare prices through reputable pet pharmacies. If they propose a wellness plan, run the math against your pet's actual needs. Many plans front-load services you'll never use. And if you sense pressure, get a second opinion. Yes, even for pets. Here's the bottom line. When a clinic's financials are engineered around rent escalators, debt covenants, and monthly KPIs, your visit becomes a revenue operation first and medical encounter second. That's not a moral failing of your vet. It's the system wrapped around them. And if pets are being squeezed inside a lightly regulated market, imagine what happens to your grandparents in facilities paid mostly by taxpayers. That's where we're going next. Elder care under pressure, nursing homes and hospice. Now take everything we've covered and turn the dial to frail, fixed income, and out of options. That's nursing homes and hospice. Most revenue here flows from Medicare and Medicaid, which sets rates, so the way to hit investor targets isn't charging more per item. It's extracting more from the same check. That's where sale-leasebacks, staffing cuts, and reimbursement games show up. Multiple national studies link private equity acquisitions to worse outcomes here, including significantly higher short-term mortality and reduced nursing hours. Here's what actually happens after a private equity buyout. Step 1. Separate the operating company from the property. The operator sells the building to a related landlord or a REIT and signs a long lease with annual rent escalators. Cash from the sale pays investors or refinances debt. But the facility now owes rising rent forever, whether census is full or not. That rent is fixed. Care becomes the variable. The lever left is staffing. Staff is the biggest line item, so hours per resident drop and the skill mix shifts. Fewer registered nurses, more aides with less training, and more temporary workers who don't know the residents. Schedules get algorithmic. Night shifts stretch thin. Call bells wait. On paper, staffing meets minimums. On the floor, people fall, infections spread, and small problems snowball because there's no one to catch them early. You'll hear operational improvements. Look at the incentives. Rent ratchets up, debt service is due, management fees come out. So the facility needs margin from somewhere. That's where reimbursement gaming comes in. In skilled nursing, Medicare therapy thresholds used to drive minutes of PT and OT right up to the cusp that paid best, regardless of patient benefit. When policies changed, the focus moved to coding acuity and length of stay optimization. In hospice, the math is different but familiar. Per diem payments make longer stays profitable, especially in routine home care. So eligibility edges widen, and discharges get messy when prognosis improves. Liability shields add another layer. Ownership is sliced into LLCs. PropCo owns the buildings, OpCo runs the beds, a management company holds the contracts, and a payroll company employs staff. When families sue over negligence, they confront a maze. Even if they win, the operating shell might be thinly capitalized. Meanwhile, the property company keeps collecting rent. Let me ground this with a micro-story. A viewer's father in a PE-backed facility fell twice in 1 week. The first time, his bed alarm wasn't connected after a sheet change. The second time, his toileting schedule was deferred during a shift change. He fractured a hip and never fully recovered. The administrator blamed unprecedented staffing shortages. But internal emails shared later showed a rent step-up hit that quarter and a directive to reduce overtime by 20%. The fall wasn't an accident. It was a balance sheet decision arriving at the bedside. You might be thinking, isn't hospice the humane alternative? It is when mission drives care. Under investor pressure, the model can twist. Enrollment can skew toward patients with longer, more predictable courses because revenue is steadier. Visit frequencies trend down. Social work and chaplain hours get trimmed first because they don't move the needle. Families report more phone calls, fewer in-person visits, and last-minute equipment delays because inventories were centralized to save costs. Everything changes when you ask, who owns the facility and who owns the land? If the landlord is a related entity, rising rent acts like a siphon. Operating budgets shrink even when public payments stay level. That's why you'll hear about new efficiencies while seeing fewer CNAs on the floor. It's not just bad management, it's the math. So what do families actually face? An impossible triangle: availability, quality, and cost. The nearby facility with open beds is often the one that maximizes throughput. The nonprofit with strong staffing has a wait list. And moving a loved one is traumatic and risky. Families accept what's available and try to fill gaps with their own labor, hiring private aides or sleeping in chairs to watch for pressure sores. That's unpaid work replacing paid care to sustain a financial structure. Here's how to push back intelligently. For nursing homes, ask for the most recent staffing hours per resident day, broken out by RN, LPN, and CNA. Don't settle for averages. Request the distribution by shift. Check state inspection reports and federal quality ratings, but look specifically at staffing and health deficiencies, not the composite score. Ask directly, is the facility operated by a company different from the property owner? Who's the landlord, and what are the rent escalators? If they dodge, that's a signal. On hospice, ask about interdisciplinary visit frequency and how often an RN will visit in the last week of life. Clarify after-hours response times and whether they staff for continuous care when symptoms spike. If the answers are vague, consider another provider, even if it means a tougher start. There's one more pattern: turnover. After a buyout, administrators churn, directors of nursing leave, and temp agencies fill gaps. Continuity dies, and with it, the tiny details that keep residents safe. How Mrs. J favors her left side, how Mr. K decompensates when rushed. Every departure is a leak in the care system. I want to be fair. Some investors do fix roofs, replace boilers, and digitize meds administration. But the dominant outcome under heavy leverage is not reinvestment, it's extraction. And the data lining up on higher mortality and adverse events after acquisitions should end the debate over whether this pressure is visible in outcomes. It is. If pets felt the squeeze in a lightly regulated market, elder care shows what happens when public money and private extraction meet. Dentistry and vision will show the pure consumer upsell engine.